Okay, we're finished with trauma now. Let's talk a bit about mixed hearing loss, because there are only a few diagnoses that cause true mixed hearing loss. Certainly you can have two different diagnoses, one causing sensorineural and one causing conductive hearing loss, but in true mixed hearing loss, it is a very limited differential diagnosis. The first thing we want to talk about here is otosclerosis. Otosclerosis is the most famous thing that causes a mixed hearing loss. It has a cochlear and a fenestral form, and I'll show you examples of both of those. But there are several mimics of otosclerosis that we need to keep in mind when we are in the setting of mixed hearing loss. One is otosyphilis, which has become so rare that it is almost never seen. But the other two are Paget's disease and fibrous dysplasia, and if we are careful, we will be able to distinguish these radiologically. Here's our first example of otosclerosis. You must look very carefully for otosclerosis because it's often very, very subtle. When you hear the history mixed hearing loss, that's your cue. That is going to remind you to look very carefully in this one particular location, this triangle of bone between the vestibule and the cochlea. That triangle of bone is the region where the normal structure, the fistula antifenestrum, lives. Now, we can't see the fistula antifenestrum, but we know it lives there, so we call this the region of the fistula antifenestrum, and that is where the fenestral form of otosclerosis is. This piece of bone right here, this triangle of bone, should be exactly the same density as the rest of the otic capsule, and you see here that it is too lucent. That is otosclerosis. Some radiologists like to use the term otospongiosis here, but I've found that the surgeons don't care for that term. Here's another example of fenestral otosclerosis. And again, to show how subtle this is, it's this triangle of bone right here. Should be just as dense. There's another example, fenestral form. Now, there's another later form of otosclerosis. This is cochlear otosclerosis, and in this case, it's a more severe disease. You see a halo of lucency all the way around the cochlea. You can see it in this in the coronal plane here. If you see it on MRI, there is abnormal enhancement all the way around the periphery of the otic capsule. This is the more severe, the more advanced cochlear form of otosclerosis. Now, there's a couple things that can look a lot like otosclerosis and can cause lucency in the inner ear, but we don't want to mistake for otosclerosis because we see them in the setting of mixed hearing loss. If you look carefully, that triangle of bone, the region of the fistula antifenestrum, is too lucent in this case, but so is everything else. And that is our clue that we're dealing here with Paget's disease and not just otosclerosis. Fibrous dysplasia is another lesion that can cause a lucency surrounding the otic capsule. In something this extensive, I don't think anyone would be fooled. You've got all these areas of ground glass, classic fibrous dysplasia. Fibrous dysplasia usually spares the otic capsule, and so this is a good clue. But this can also cause mixed hearing loss, and will be on our differential diagnosis. Okay, let me speak specifically about one particular diagnosis, superior semicircular canal dehiscence. Superior semicircular canal dehiscence presents with a symptom called Tullio's phenomenon. Tullio's phenomenon is dizziness in response to a loud noise. So, for example, someone will walk into a party and suddenly get dizzy. Or a truck driver might say, when I walk down this side of my truck, I get dizzy, but this side I'm fine, and it's which ear is closest to the engine. It's causing the noise causing the dizziness. Tullio's phenomenon used to be associated with otosyphilis, but as otosyphilis has diminished in frequency, we've started to associate it more with superior semicircular canal dehiscence. So what's superior semicircular canal dehiscence? That's when there is a hole in the bony covering that normally covers the superior semicircular canal. So pressure can go from the semicircular canals into the cranial vault. And there can be transmission of pulsation between the inner ear and the intracranial vault. This is called a third window phenomenon. We should only have two windows. We should have a round window and an oval window into the inner ear. And the reason you have a round window is so that when you press on the oval window with the stapes, the round window allows that fluid to shift. It's a carefully orchestrated scheme that allows this fluid to shift in one window and come out the other. If you add a third window on that superior semicircular canal, it's all messed up. And those vibrations, instead of a nice, neat shifting of fluid, instead the fluid comes out here, it doesn't shift right, and the whole system is messed up. So it's that third window phenomenon that allows this to happen. Now, many people have advocated for the planes of Stenver and Paschal as a way of carefully looking for superior semicircular canal dehiscence, and I'll show you what it looks like in those planes. The reason we need separate planes of imaging is it can be a very near thing whether the superior semicircular canal is intact or not on an axial image. So we need some help from reformatted images. So we are going to take reformatted images along the superior semicircular canal and perpendicular to the superior semicircular canal. The ones that are perpendicular are the plane of Stenver, and the ones that are along the superior semicircular canal is the plane of Paschal. So here's what it looks like in the plane of Stenver. This is a normal superior semicircular canal, a nice bony covering on top of it. This one, dehiscent semicircular canal, you can see there's no bony covering on the top of the canal. Plane of Paschal, same idea. Here is a nice bony covering over the superior semicircular canal, and here there is a gap over the top of the superior semicircular canal. But now I'm going to let you in on a secret. You don't need the planes of Stenver and Paschal. Your basic, everyday coronal reformat is perfectly good for this diagnosis. It performs just as well as the planes of Stenver and Paschal. They are fun to play with, but they don't improve your diagnostic accuracy. So if you don't like looking at that many images, this will do just fine. You can see the intact bone over the semicircular canal on this coronal and the dehiscent bone over the semicircular canal on that side. There are no classic imaging findings for Meniere's disease, also called idiopathic endolymphatic hydrops. What's happening here in this disease is that the endolymphatic cavity in the center of the membranous labyrinth is expanding at the expense of the surrounding perilymphatic cavity. And so this disrupts the normal fluid dynamics in the membranous labyrinth. So how can you tell the difference between the endolymphatic cavity and the perilymphatic cavity? You have to distinguish between them to note that one has enlarged at the expense of the other. Well, one way you can do this is you can put a needle through the tympanic membrane and inject some dilute gadolinium and then wait for 24 hours and it turns out that the perilymph preferentially takes up the gadolinium, and you can see this on 3D FLAIR sequences. These produce beautiful images. They are very high specificity. You can definitely identify patients with Meniere's disease. But to wait 24 hours and then reimage is very inconvenient for patients, and it's an invasive test. You have to put a needle through the tympanic membrane. If you don't like that, you can do something that's not quite as nice, but still very useful, and that's delayed post-contrast imaging. If you give intravenous contrast and wait 4 hours, again, the perilymph preferentially takes up that gadolinium, and you can do high-resolution FLAIR imaging, and you can get good images. They're not as nice as the intratympanic injection, and they have moderate specificity. This is only moderately inconvenient because you're waiting for 4 hours. Still not very convenient. But there's one other option. The other option is your usual SSFP, or KISS, or Fiesta sequences. And this is part of every single examination of the inner ear that you already do. You're already doing this every single time. Now, if you use this, it has the lowest specificity. They aren't as pretty pictures, you're not as certain of your diagnosis, but it's very convenient because you're already doing it on all of your patients, and you can go back to patients that you've already looked at and look again. Let me show you an example of what we are looking for in endolymphatic hydrops here. Notice, if you look very carefully, that in this even though there's high T2 signal throughout the entire inner ear here, there's a small stripe of slightly darker T2 signal down the center. That is the endolymphatic cavity, and the perilymphatic cavity is around it. And normally it is just a very thin stripe like we see here, very small amount of endolymphatic fluid. If that endolymphatic cavity expands and more than about 1/3 of the vestibule has endolymph in it, and now you can see how much larger the endolymph is here compared to here at the expense of the perilymph, that is suggestive of Meniere's disease. Not diagnostic, It's not as good quality as these contrast images. It's not diagnostic, but you can suggest the diagnosis, and the patient may go on to more confirmatory clinical testing.